my talk in the virtual SOHO meeting this year has focused on the use of BCL-2 inhibition in myelodysplastic syndromes, which I think is a very important and timely subject. As the audience knows, acute or myelodysplastic syndromes, when they are higher risk, they are associated with poor prognosis. And while we have approved treatments such as hypomethylating agents, the azacitidine and decitabine, the survival with those agents as monotherapies have been quite poor, especially when you look at real-life outcomes. We actually have conducted several large registry and population-based studies in which the median overall survival after hypomethylating agents was in the range of 11 to 17 months, which is shorter than what was reported of 24 months with the landmark AZA-001 study with azacitidine. After hypomethylating agent failure, which is bound to happen in almost all patients, the survival is even worse, around 6 months. So because of those numbers, there has been continued interest in studying new agents for MDS that can improve outcomes. And since 2006, when Decitabine was approved, we really had no approvals in the US until this year, 2020. We had 2 new drugs approved in 2020. One was Luspatercept for lower-risk MDS, and the other was an oral version of Decitabine, both approved in 2020. However, I think a very exciting element is a large number of novel agents that are being tested in now phase 2 and phase 3 trials, and one of them is Venetoclax. So Venetoclax basically is an oral highly selective agent that works on the apoptosis pathways. So those apoptosis pathways are generally exploited by cancer, and multiple type of cancers will overexpress anti-apoptosis proteins to try to basically extend the survival of the cell and avoid dying effectively. So when apoptosis is dysregulated, basically this gives a selective advantage for the cancer cells and proliferative advantage. So Venetoclax, what it does is basically it inhibits one of the most important regulators of this pathway, the BCL-2, and basically leads to activation of apoptosis, the intrinsic pathway which leads to cell death. And this seems to be preferential in patients with hematologic malignancies, first shown in CLL and subsequently in myeloid malignancies. We just had a large phase 3 trial of Venetoclax published in the New England Journal of Medicine, in which the overall survival in combination of Venetoclax with azacitidine was almost 15 months compared to 9 months with azacitidine monotherapy. And this drug has been already approved for a couple of years now in the US. Because of that, and because of a lot of preclinical data suggesting synergy between azacitidine and Venetoclax, this combo has entered trials in high risk MDS. So there were 2 trials that have been conducted to date, one in the frontline setting and one in the refractory relapsed setting. So the frontline setting, the combination of Venetoclax was done with azacitidine at the standard dosing of 75 milligram per meter square given for 7 days in a row. The Venetoclax initially was administered continuously, similar to what is done in acute myeloid leukemia. However, there was an increased incidence of infectious complications and deaths, and the trial was redesigned so that Venetoclax was only given on day 1 through day 14, which has been adopted in all subsequent assessments in patients with MDS using Venetoclax. The dose was escalated in a traditional dose escalation format from 100, 200, 400. As there were no DLTs, the higher dose of 400 milligram given, as we mentioned, for the first 14 days was taken into a safety expansion. So the total enrolled patients were 57 in the phase 1 trial that was presented by Dr. Andrew Wee in ASH 2019. And in terms of safety, the combination was mostly associated with the cytopenias, myelosuppression, which is expected, but also with infectious complications such as febrile neutropenia and some GI side effects. However, those were well managed by supportive measures, and the patients generally were able to tolerate this combination relatively well. importantly, use of prophylactic antibiotics is important, especially in the first few cycles when the patient is quite neutropenic. The most exciting element, of course, is the high activity that was observed. So the overall response rate was 77%, which compares with around 50% with HMA monotherapy. And the CR rate is around 40%, which compares to around 15% with monotherapy. However, this was a single-arm trial. It's a phase 2 trial. So I think further evaluation is important. And actually, a phase 3 trial has just been launched to evaluate this combination, azacitidine with Venetoclax versus azacitidine with placebo. And this trial, I think, will provide a definitive answer in terms of not only the response, but also the survival with this regimen and the improvement. Another trial that was presented in the relapsed refractory setting, which I presented on behalf of my co-authors in ASH, and this got updated in the EHA meeting this year, in which patients were treated with monotherapy of Venetoclax, which was well tolerated, but the activity was poor clinically. So the focus was in the combination with azacitidine. 44 patients were enrolled. The safety profile was similar to the frontline setting. You could mitigate this, basically the infectious complications largely by the use of prophylactic antibiotics and aggressive supportive measures. In terms of activity, the overall response rate was 41%, 7% were CR. And again, you have to remember that this is after HMA failure. Most of the patients have received a lot of prior HMA cycles. The median number was 9 cycles. So heavily pretreated refractory patient population. So I think a 40% response rate, including 7% CR, and many of the marrow CRs also had hematologic improvement, is actually quite promising. Also important to note that the median overall survival in this trial was around 12 months, which compares quite favorably with basically the median overall survival in historical controls after HMA failure, which is around 6 months. So I think both of those trials support further study of Venetoclax in combination with azacitidine. I think the future questions are going to, look at what are the predictors for response, how can we predict resistance and try to prevent resistance from emerging quickly, and also how to mitigate resistance, and also try to understand other forms of combinations, basically, such as oral therapy with, for example, with oral hypomethylating agents, with oral Venetoclax, like a doublet oral therapy. That would be quite, I think, a very interesting evaluation to do now that we have an oral Decitabine version that has been approved and already in use as monotherapy in the US. So I think the field is quite promising. There are a number of other agents that I think are also quite promising, and I think the field is going to change significantly in the next few years for patients with high-risk MDS.